Welcome in from wherever you're tuning in from. Really, really excited to dive into some high yield step one gastroenterology vignettes with you guys and then build in lots of content integrations and some high yields that I think are really going to help when you're going through both your NBMEs and then step one as well. This is going to be a really interactive session, so make sure you're ready to type answers to the questions in the chat box. This is going to serve as a great studying tool for you guys and practice with some active recall. Hi, everyone. I'm seeing everyone in the chat here. We'll probably wait maybe another minute or so before we dive in. Today, we're going to be going through 10 high yield vignettes. So get ready, get excited, because we're going to be learning lots. Amazing. I'm seeing lots of people in the chat. We've got 78 people here, which is amazing. All right. Well, Fahad and Khalid, you guys can monitor the chat and anyone else who's going to be admitted throughout the presentation. But welcome in, everyone. So excited to have you all here and joining me for this really high yield session. We're going to be diving into topics of gastroenterology, but I've designed this webinar where we're going to be pulling integrations from other systems, other disciplines to really help you guys see the full picture with some of these concepts. Today, we're going to be doing a really fun giveaway of my gastroenterology guide. So all of the content you see within this presentation, as well as the vignettes, are actually right from my gastroenterology guide. All of my resources can be found on my website. But this webinar, as well as all the webinars we run for our community, all happen in our Discord. And so right here, we're going to be doing this giveaway at the end of the presentation. But if you guys are at all interested in our weekly webinars or just being in a community with thousands of pre-med and med students where we interact with each other, there's fun giveaways, we do question of the days, we have personal advising. So if any of that interests you, this is a unique QR code that will give you 50% off lifetime access. So it's really just $4.99 a month. And you guys can be a part of the community with lots of other students who are trying to do the exact same thing. And it's just great because we can all support each other and answer all the questions you have as you go through your journey. So be sure to stay tuned for that. We will be also giving away my guide at the end. Just a brief intro. My name is Jake, and I'm a third-year medical student here at the University of Queensland. I wrote Step 1 now about a year ago, and really it's been a passion of mine to share the way that I prepared for the exam, and really I think inspired by a visual approach. I keep on bringing up the word integration because I really do think learning these concepts in isolation is not the most effective way. And so you'll see throughout this presentation, I try to draw on all the other systems to bring these things back into, how all these processes are related and how the NBME and USMLE are often going to test concepts. I'll briefly pass this on to Fahad and Khalid, who are two lovely mentors that I've been able to work with to just introduce themselves.
Sure. Thank you, Jake. So I'll go ahead and go first. Good to meet you all. My name is Fahad, for those of you who I haven't met. So I went to Penn for the University of Pennsylvania in Philadelphia for undergrad and was also very interested in the medical education space. So naturally, as I continued working on that, kind of in that space over medical school at the University of Pennsylvania as well, Khaled and I were fortunate enough to partner with Jake on this amazing Discord that you'll hear more about today. And so a little bit more about me. I'm, very interested in dermatology, and I'm happy to say that I'm starting at the University of Miami in the coming months as a dermatology resident. And I'll pass it on to Khaled.
Yeah, Fahad took a lot of the intro, but my name is Khaled. I went to Boston University for undergrad and the University of Pennsylvania for medical school. Met Fahad literally within the first week of medical school, have been friends ever since, and we'll both be at the University of Miami, but I'll be an ophthalmology resident hopefully starting next month.
Awesome. Thanks,
Thank
guys. So briefly today, this is just the overview of the concepts we're going to be covering. So you can see we're going to be starting from embryology and then going through the GI tract and then finishing off with some pancreas, liver, and some anatomical relationships with our hernias. All right, without further ado, let's dive into the first vignette. We're going to be starting off with embryology, which is very high yield when it comes to the gastrointestinal system. So let's have a read of this vignette, everyone. So we have a 28-year-old pregnant G1P0 woman undergoing routine prenatal screening at 20 weeks gestation, including a fetal ultrasound and maternal serum alpha fetal protein. The ultrasound reveals a central protrusion of the abdominal contents through the umbilical ring. Maternal serum AFP levels are found to be elevated. Okay, pertinent positive here, important. Which of the following conditions is most commonly associated with this patient's findings on prenatal screening? Now, this might be a little bit of a tricky one for you guys, but we're going to be starting off. Okay, let's see. Everyone in the chat box, I want you to put in your answer. Today, there are no wrong answers. This is the best for your learning to contribute in the chat. Okay, so we're getting lots of mixed answers. We have A's, we have C's. Okay. Lots of A's and C's. Now, this is a really tricky one, and I purposely put this here because I think there's a lot of learning opportunities. Okay, now I'm starting to get some D's. So if you said D, you are correct. We are going to be going through this vignette in a lot of detail on the coming slides. But does anyone want to know, or does anyone want to put in the chat box what they think the provisional diagnosis of this patient is? Think of perhaps a ventral wall defect. Okay, I'm seeing omphalocele, okay, so really, really great. If you're saying omphalocele, you're absolutely correct, and this is what's going to tie into our trisomies. But first and foremost, what I want to do here, guys, is I want to go over the ventral wall defects and why it was that and not something else, okay? So first and foremost, I want to differentiate between the answers that you guys have been putting in the chat, which is omphalocele and gastroschisis, which are both similar, but they differ in one key way. Now, the key way, and a memory trick that I love honing in on, is that on omphalocele, you're going to draw an O like this, which is a completely closed system, to help you remember that the abdominal contents are actually still sealed within the peritoneum, okay? And in particular, the omphalocele is actually going to be associated with your congenital abnormalities like trisomy 13, 18, and Beckwith-Wiedemann. Remember, with Beckwith-Wiedemann, you're going to be thinking of macrosomia, right? Large body size at birth. You're going to be thinking large tongue, macrosomia, hypoglycemia, and all those features. To contrast, gastroschisis, the G is not a closed system. This is going to help you remember that the abdominal contents are going to protrude out, right? And they're not going to be covered by the peritoneum. Now, gastroschisis actually has a more favorable prognosis because it's not associated with these other congenital abnormalities. And so gastroschisis is not going to have the associations that you saw in the previous vignette of the trisomies or the neural tube defects. Now, neural tube defects, you guys are correct in thinking that the alpha fetal proteins are going to be high, but the vignette spoke about a central protruding mass, right? In a neural tube defect, you're not going to assume that that's going to be the presenting feature, right? So just be careful with reading the full stem as you go through it. And then finally, the last ventral wall defect that I want to touch on is the congenital umbilical hernia, which is associated with trisomy 21 and cretinism or hypothyroidism, congenital hypothyroidism. However, these are very benign. They actually typically spontaneously resolve by the age of 2 or 3, and you're not going to be expecting signs of increased alpha fetal protein, for instance, and these typically have a more benign course. So now I want to go into something super high yield, and this is where perhaps some of you were struggling with the answer choices. And I want to go through the 3 high yield trisomies and the USMLE vignette features you can expect to see, okay? So let's start off with trisomy 13, Patau syndrome. I like to remember that it's trisomy 13. Patau syndrome is 13 letters. And I want you guys to hone in on this really easy way to remember all the features. And that is going to be with your midline defects. So now let's go through from top to bottom and thinking about midline defects. Okay, so midline, the head and the lip, we're going to be thinking microcephaly and cleft palate. MSK, you're going to get these classic rocker bottom feet. Coming back to our vignette and the answer choice of trisomy 13 as it relates to omphalomastele, right? In our GI system, you're going to get this central ventral wall defect to also help you remember the midline defect. And then finally, your heart, VSD, and PDA. I want you to keep these associations in, yes, aplasia cutis is also, this is not an extensive list, but these are the high yield ones that I've seen commonly appear on UWorld and NBMEs. Okay, moving on to Edward syndrome, which is going to be trisomy 18. You can remember the E's, Edward with 18. And I have a little fun mnemonic here. Edward, you're going to remember elongated skull. Classically, the clenched fist are the giveaway in a vignette. You're going to have your VSD, apnea, rocker bottom feet, and then your classic low set dysplastic ears. And then finally, trisomy 21, Down syndrome, developmental delay, duodenal atresia, which is going to present right with your bilious vomiting and your double bubble sign on X-ray. Oblique palpable fissures, which is your upward slanting eyes. You're going to have that wide gap between your first and second toes, your nasal flatness, and your single palmar crease. So these are just really, really important associations to look out for in the vignette that they're going to be describing. And I wanted to put some emphasis on the GI focused ones, of course, as this is a GI focused webinar. And so pay attention for omphalomastele as it relates to trisomy 13 in particular, and then think about trisomy 21 with your duodenal atresia and that double bubble sign that we talked about. Okay. And I know that some people have some questions. I will just save those questions to the end and make sure that those are answered for you guys. But I did want to just move on to, because we do have lots to cover in this lecture. And so we'll dive into this next vignette. So here we have a three day after delivery, we have a 3,500 gram newborn baby who has multiple episodes of bilious vomiting. The baby was born at 29 weeks gestation, so we have a preterm. And the early newborn period was significant for a delayed passage of meconium at 60 hours of life. Physical exam is significant for a distended abdomen. Digital rectal exam is significant for an elevated sphincter tone and release of stool after digit is removed from rectum. Which of the following is the most likely underlying etiology of this newborn's findings? So please, again, guys, everyone, I want to see your answers in the chat box, and then we will be going through this next vignette. Okay, lots of E's, which is great. If you're saying E, you're absolutely correct. And I just want to hone in on a couple key principles here, okay? So first and foremost, we have bilious vomiting. Can I get you guys in the chat box to give me some differentials if you see bilious vomiting? Hirschsprung's, that's a great one. Yep, and I think that's exactly what we're seeing in this. Yeah. Okay. So pyloric stenosis, everyone, is actually going to be non-bilious vomiting. Now, I want everyone to understand this. Our ampulla evader, right, where our pancreatic ducts, right, and our gallbladder is going to connect to the duodenum, right? This is at the ampulla evader. If you get an obstruction or an issue proximal to the ampulla evader, that means the bile hasn't mixed in with the chyme yet, right? And so at that stage, you're going to actually have a non-bilious vomiting. So something in pyloric stenosis, right, in the which is part of the stomach, and we haven't yet reached the duodenum, you're going to expect to see a non-bilious vomiting, right? Other causes of non-bilious vomiting, guys, you're going to think of just your GERD, potentially gastro, or those inborn errors of metabolism. Distal problems, right, that we're talking about, like in this passage, which many of you guys identified, which is our Hirschsprung's. Then you're going to get bilious vomiting, which classically, right, is that green color, green-yellow color. Other things to think about are your volvulus, your obstructions, intussusception, malrotation, and then both biliary or duodenal atresia. So does everyone understand how the anatomical relation of the ampulla evader and whether there's an issue proximal or distal is going to help you identify whether we have bilious or non-bilious vomiting? Does that make sense to everyone? Okay, amazing. And so if you guys are absolutely correct if you were saying E though, and in this vignette in particular, we are thinking of Hirschsprung's disease. Okay. Now, I wanted to just take this opportunity to go through some physiology of the gut because, again, as we were saying, I don't want to just talk about Hirschsprung's and failure of the neural crest cell migration, right? I want to understand why this occurs and how it relates back to the physiology. Okay, so we can generally think of the organization of our gut layers in this format: SMSM. So if your serosa or your adventitia, whether you're in retroperitoneal space or not, it's serosa versus adventitia. Then we have our muscularis propria, which both has a circular layer of muscle, a longitudinal muscle, but it also contains something called our Auerbach's plexus or our myenteric plexus. Then under that, you're going to have your submucosa, which is your Meissner's plexus. This secretes the fluid and the lubrication. And then mucosa underneath that is going to be your, classically, right, your epithelium, your lamina propria, etc. And so a little quick memory trick here. I think of the M's in myenteric with the muscularis propria and motility to help me remember that functionality. And then for Meissner's, the two S's help me remember the submucosal aspect and the secretion of fluid. Now, why I put this here is because we have to understand how Hirschsprung's disease and something called achalasia, right, is going to relate to this. So in Hirschsprung's disease, as you saw in that vignette, you're actually going to get a lack of the ganglion cells. Reminder, your ganglion cells come from your neural crest cells, right? Remember your Motel past mnemonic for your neural crest cell derivatives, highly tested on USMLE. And it's going to be failure of these ganglion cells, right? These lack of ganglion cells, specifically in the distal colon. And this is why you get this classic congenital megacolon picture. And in the vignette, look out for, right? Failure to pass meconium over that 48-hour mark. And there's two differentials I want you guys to keep in mind. So you see a vignette, and the vignette is presenting with failure to pass meconium over 48 hours. There's two things I want you to think about. That's either Hirschsprung's disease or that's cystic fibrosis. Now, how you're going to differentiate the two is that in Hirschsprung's disease, right, you have this megacolon. It's going to be highly associated with your congenital abnormalities like Down syndrome. And you can remember Down syndrome with distal because this affects, of course, the distal colon. And then finally, the other thing is you're going to have a different means of testing, right, diagnostically for Hirschsprung's versus cystic fibrosis. We will get into the diagnostic test for Hirschsprung's after I talk about achalasia. But to contrast, in cystic fibrosis, right, that's your microcolon. You're often going to see a picture of failure to thrive, recurrent sinopulmonary infections, right? The CFTR mutation, that diagnostically, you're going to do the sweat chloride test, right? So just keep in mind those two differentials. Of course, both can present similarly, but look out for those other features to help distinguish the two. Now, achalasia is also going to be a problem, right, with one of the physiological layers of the gut, and that's going to be a degeneration of the inhibitory neurons of the myenteric plexus, okay? Now, this can be due most commonly in a primary sense idiopathic. We don't know why. But secondary can be to something like a T. cruzi infection. So look for travel to South America, and that can progress to Chagas disease, right, where you get even the megacolon, the mega esophagus, and you can get features of dysphagia, etc. Classically, with this one, guys, you're going to see this bird beak appearance on barium swallow, and look at this lower esophageal sphincter, right? It all tapers down there, and so you're going to look for increased pressure on manometry, and they could give you a manometry wave, and you'd have to identify that is achalasia. But again, I wanted to talk about the physiological layers of the gut and then build in Hirschsprung's and achalasia because, again, it's directly related to these concepts. And just going back to the question on Hirschsprung's disease and diagnostic testing, do you guys in the chat box want to put in what is the standard investigation for Hirschsprung's disease? Yeah. If you're saying rectal suction biopsy, you're absolutely correct. Yep. Really, really good, everyone. Because think about it, right? The submucosa is where the ganglion cells are. So we need a rectal section biopsy to look at that layer. Exactly. Really, really good work, everyone. Now, just going through the other answer choices that were incorrect. Whenever you're thinking vascular accident, you're thinking jejunal atresia. The B was related to duodenal atresia, and then the telescoping, right, is your intussusception, and then we talked about neural crest cells and how it relates to the distal colon and Hirschsprung's. One other thing I wanted to bring up, guys, is look out for this RET mutation, and there's two. Remember, RET is a proto-oncogene, right? It's a receptor tyrosine kinase. that's constitutively activated. And there's two high yield associations with the red. One is Hirschsprung's, and the second is your MEN2, right? Your multiple endocrine neoplasias, right? Remember, your MEN2 syndromes is going to be RET mutation, okay? And remember, right, your MEN2A is going to be your PHIO, your parathyroid hyperplasia, and your medullary thyroid carcinoma. And then your MEN2B is going to be medullary thyroid, mucosal neuromas, marfanoid, and PHIO. So really, really good work, guys. And let's move on to another GI physiology question. Yeah, MEN2, really, really good work, guys. So now we have a 55-year-old male who presents to the clinic with complaints of recurrent epigastric pain, especially after meals. He reports relief with antacids. Upper endoscopy reveals erythematous mucosa in the gastric antrum with multiple erosions. Biopsy confirms the presence of Helicobacter pylori infection. Which of the following hormones primarily stimulates parietal cells in the stomach to produce gastric acid in response to gastrin? Everyone in the chat box when you are ready for this next question. Really, really good, everyone, if you're putting B, because histamine is going to be correct here. So what I wanted to do on this next slide is do a little fun pathway for you all. And I want you to follow this line of thought in this flow chart. So food is going to enter the stomach. And we know we have multiple cells in our stomach that are going to be responsible for various things, right? We have our vagus nerve. That's going to be primarily, right, our parasympathetics that are going to be innervated and are going to directly stimulate these other cells, right? We have our enterochromaffin-like cells. We have our G cells that are going to stimulate and secrete gastrin. And then we also have our parietal cells. So the question was asking what directly stimulates the parietal cells to secrete hydrogen ions and intrinsic factor. And you were correct if you said histamine, right? The ECF cells. But just remember that the G cells, gastrin, that's easy to remember. Enterochromaffin-like cells is going to be your histamine, and then your parietal cells is going to be your hydrogen ions and intrinsic factor. And guys, really, really important to tie this back into your biochemistry. Parietal cells, right? They're going to actually be working on primary active transport, right? Your sodium ATPase, okay? And something like a proton pump inhibitor, right? Your prazoles, those are going to inhibit that ATPase because we want to decrease that acid or hydrogen ion secretion. And something key to keep in mind here, guys, is the relationship of parietal cells, intrinsic factor, and B12 absorption. Reminder that intrinsic factor is going to bind your B12 right in your stomach, and it's going to travel all the way to your terminal ileum where it's going to be absorbed. And so I want you to think of B12 deficiency, right? Your macrocytic anemia, your MCV greater than 100, those associations. But I want you to identify that it could be a problem in the stomach itself, like a pernicious anemia, right? When you get autoantibodies to the ATPase, or it can be a problem in the terminal ileum, right? Think of things like Crohn's disease or anything that's going to, or your diphylolatum tapeworm, right? That's going to affect the terminal ileum where the B12 is absorbed, and then you're going to look out for signs of B12 deficiency. So really, really important to keep in mind these parietal cells and how important this is. They love testing intrinsic factor and its relationships with that. A little fun memory trick, guys, is that gastrin, you're going to think gastrin all stimulatory because it's essentially the first one in the pathway that just stimulates the ECF cells to produce histamine, which then stimulates the parietal cells to secrete hydrogen. So remember that. And then you're going to remember that you have something called somatostatin that comes from our D cells. And I want you to think of somatostatin as somatostasis because it inhibits. Stasis, think inhibiting, okay? Now, so we just talked about food entering the stomach. Now I want to think about food exiting the stomach, okay? And there's a couple of cells that we're going to talk about. So now our acidified contents are going to enter the duodenum, okay? We have our I cells that are going to secrete CCK, and that's going to have three functions. First, from the pancreas, it's going to increase those prodigestive enzymes, right? Your trypsinogen, et cetera. For the gallbladder, probably most importantly, it's going to stimulate it to contract and secrete bile, right? Help emulsify our fats. And then finally, it's going to decrease gastric emptying and increase transit time. So it's going to keep the food in long enough to digest and break down those micronutrients. And finally, our S cells, you can remember S cells with secretin, those are going to stimulate both the pancreas and duodenum to produce bicarb, which is going to help neutralize our gastric chyme. So that's the flow chart there. I hope everyone was following that. Excuse me. Really important integration as well, guys, is I want you to think about your types of receptors. So remember that like H2, for instance, right? Our histamine is going to be H2 as it relates to the ECF cells, and that's GS stimulated, right? Remember that our H2 blockers are tidine suffix, right? They can ask you, like basically what I'm trying to say is the USMLE can ask you and go back into the biochemistry or receptor signaling as it relates to any of this. So really make sure to focus on those basic science principles when it comes to the step 1 exam, and make sure to have all those relationships integrated as you're going throughout your study, okay? But super, super high yield to remember that your sodium ATPase is our primary active transport mechanism. And then secretin is going to be stomach everything inhibited, right? It's going to neutralize and increase bicarb production. All right, stomach pathology. Everyone following along? I think this is our 3rd question now. So everyone stay active, stay engaged. Let's get on to this next vignette. So we have a 65-year-old female with a past medical history significant for class 3 obesity, severe osteoarthritis, and hyperlipidemia who presents to the emergency department with complaints of epigastric pain and nausea. She reports taking the following medication. So she takes a statin, 40 milligrams once daily, naproxen, 500 milligrams every 3 hours, and acetaminophen, 325 milligrams 3 times daily. She drinks alcohol socially, typically 1 glass of wine every weekend. She weighs 80 kilos, is 155 centimeters tall, BMI 29.4. Upper endoscopy reveals diffuse erythema and erosions in the gastric mucosa. Which of the following mechanisms best explains the development of acute gastritis in this patient? So I want everyone to put their answers in the chat box when you guys have. I want every single person, all 120 of you. That's absolutely amazing. I'm so happy we have so many of you here to put your answer in the chat box. Okay, so I'm getting mixed A's, B's, D's, C's. We're gonna go through each one of these. Actually, let's talk about this for a second. So the correct answer is going to be C, but let's go one by one, and then we're going to dive into the kind of the physiology and the pathophysiology here. Direct mucosal irritation, guys, you're thinking chemical gastritis, okay? That can be through medication or that can be through alcohol. But what I want you guys to understand is, in particular, what's the risk factor really presented in this vignette, okay? Yeah, she drinks alcohol socially, but it's not enough for me to think it's more of a mucosal, chemical gastritis picture. I'm really thinking, wow, naproxen, which is an NSAID. She's taking that every 3 hours, a pretty high dose. Exactly, medication, NSAIDs. You guys are absolutely correct, right? Inhibiting our COX pathway, prostaglandin synthesis downstream, also our thromboxane and all those other things, right? So really, really good job if you guys put C. B, decreased gastric acid secretion, right? What did we talk about? Autoimmune gastritis, like something like a pernicious anemia, where you get autoantibodies to your parietal cells, right? Now you're not producing, you get achlorhydria, and that's going to actually decrease the protection, but that's through a different mechanism, right? And then we talked about decreasing prostaglandin synthesis already. Increased vagal stimulation, we're going to talk about something on the next slide for that. So acute gastritis, right? Think about the layer of the serosa and epithelium of the stomach, right? It's lined and protected by our prostaglandins. That's super, super key for you guys to understand. And so our naproxen, right, our NSAIDs, if you guys go back into your COX pathways, right, your COX-1, COX-2, and downstream of that, you're going to get your prostaglandins and your thromboxane. Remember, thromboxane, right, is going to activate aggregation, platelets, right? If you decrease or inhibit this process through NSAID use, you're both going to decrease your prostaglandins, which is going to put the mucosa at a higher vulnerability for damage and ischemia. But secondary to that, right, you're also going to inhibit platelet aggregation. And that's why your NSAIDs are a multifactorial use, right? And whether they inhibit COX-1 or COX-2, right? Remember, COX-2, celecoxib, has selective preference for COX-2, but you guys can review that in your own time. I just want to really hone in on the principles of the COX pathway because it is important and highly tested. So another of the answer choices was vagal stimulation, but this is something in a brain injury that you could suspect. So remember that your primary neurotransmitter in the PNS is going to be your acetylcholine. So really, really high yield to remember that vagal stimulation, right? Let's say there's a brain bleed or brain injury or whatever. That high pressure is going to increase vagal stimulation, which is going to increase your ACH and increase H plus secretion. Little fun memory tricks always cushion the brain, or in a burn picture, which is due to hypovolemia, which can lead to ischemia. You can remember burn by the curling iron because that one's called a curling gastritis, okay? Now, if you get repeated bouts or chronic use of something like an NSAID, we saw that patient taking 500 milligrams of naproxen 3 hourly, right? Then you can get something called chronic gastritis. And we've already talked about type A a little bit, which was that autoimmune pernicious anemia, right? The antibodies to your parietal cells, where you can get this low acid and achlorhydria. But secondary to that, what we see in the vignette, it was confirmed H. pylori infection. And so I wanted to integrate H. pylori here because it's very high yield. And all of these things that you see here listed are honestly very high yield. The first is that, remember that it's catalase, oxidase, and urease positive. I remember triple traits, triple therapy, because we also use PPI, sclerothromycin, and amoxicillin or metro as a means of pharmacological intervention. But really here, the virulence factors is where I want you guys to pay attention to, right? It releases this exotoxin VAC-A, which is going to directly cause gastric mucosal injury, right? And lead to this type B chronic gastritis picture. And then specifically it's the endotoxin, which is KAGA, that can actually contribute to gastric cancer. And the urease positive is going to help you remember that the H. pylori is really, really good at living in the stomach because it can neutralize its own gastric acid. So essentially, the acid that's produced in the stomach can kill a lot of bacteria, but one of the virulence factors that H. pylori has is this urease, and this urease helps it neutralize and essentially stay hidden, okay? And so stay on the lookout for H. pylori and how it relates to gastritis. All right, small intestine pathology. You're a 30-year-old female who presents to her gastroenterologist with complaints of chronic diarrhea, bloating, and weight loss. She reports worse symptoms after eating and has an itchy rash on her elbows and knees. Serologic testing reveals elevated levels of anti-tissue transglutaminase, anti-TTG antibodies. EGD, definitely not ECG, EGD, with biopsy is performed and the sample is sent for a microscopic analysis. Which of the following best describes the histologic findings obtained from this patient's sample? So first and foremost, I want you guys to think, what is this diagnosis? Celiac, absolutely correct. And if you are saying B, which is blunting of villi, intraepithelial lymphocytes, and crypt hyperplasia, those are hallmark features that you expect to see. Yep. Really good, everyone. What you'd expect to see in celiac. Let's quickly go through the other answer choices, though. Normous villus architecture with increased intraepithelial lymphocytes. That's going to be more in keeping with IBD. Marked eosinophilic infiltration of the lamina propria. That's your eosinophilic esophagitis, right? We're not seeing any signs of dysphagia, etc., or other esophageal symptoms. Often that is associated with your atopic triad as well. So things like eczema, rhinitis, allergies. The absence of goblet cells in the intestinal epithelium is a microscopic colitis, and then presence of granulomas in the lamina propria is your Crohn's disease, right? So let's just go quickly through what you'd expect to see on histology, because they could also just provide the histological image here, right? But I did have a fun little memory trick here to illustrate this blunting of villi. As you can see, these nice papillary projections, right, of the villi are intact here in the normal villi. But in celiac, you get this blunted shape. You get the hyperplasia of these crypts. Look at these. Look how large these crypts are here. And then you'll get a lot of these intraepithelial lymphocytes, right, in the lamina propria, as you can see here. So, because it wouldn't be a MedSchoolBro webinar without all my fun mnemonics, we got celiacs for celiac disease. So you can think of chronic or recurrent cheek ulcers, the enteropathy, loss of villi, and increased risk for T-cell lymphoma. That's high yield. Intolerance to gluten, of course, the pathophysiology, and then it's an autoimmune picture, right? We've talked about our IgA, anti-TTG, and anti-gliadin. You're going to get that crypt hyperplasia, and then that itchy rash that was described in the vignette is going to be something called dermatitis herpetiformis, and it's going to classically affect the second part of the duodenum. So hope that helps. And I have another fun memory trick you're going to remember the gut is sealed by glue. So remember, sealed is gluten. Gluten can't be eaten. And the glue is going to help you remember the anti-tissue transglutaminase. Okay, very high yield. And then finally, it has associations with HLA, DQ, and D8. Sorry, DQ8 and DQ2. And it's a classic type 4 delayed hypersensitivity reaction. So just a couple memory tricks and fun mnemonics to help you guys out. And then celiac mimics. So right in that picture, in any malabsorption problems, you're going to be thinking of steatorrhea, chronic diarrhea, bloating, weight loss. And often they can present very similarly as these other conditions. So I want you guys to look out for the differences in celiac with Giardia, tropical sprue, and Whipple's. Giardia, right? Remember that you're going to get these multinucleated trophocytes in the stool, so you're going to get a stool sample. And tinidazole and metronidazole are going to be first line. Really look out, guys, for that fatty stool, steatorrhea in all these pictures. Now, a tropical sprue, you're going to be looking in the vignette for recent travel history to a tropic area. The key with tropical sprue, guys, is that these will classically respond to antibiotics, okay? These will classically respond to antibiotics. Of course, here we're going to need other targeted pharmacotherapy, and we're going to need different pharmacological interventions for celiac, okay? For celiac, really, the number one thing in terms of management is to avoid gluten, okay? So that's going to be the biggest thing there. And then for Whipple's disease, you can think of Whipple's, weight loss, hyperpigmentation. It's going to be infection with your Treponema whippleyi. Remember these classic pass positive, right, foamy macrophages on your histology, and you're going to get all these other features too, typically of like the polyarthritis, lymphadenopathy, enteric involvement, and then of course all of the celiac and celiac mimics are typically going to present with that, steatorrhea, chronic diarrhea, bloating, those kinds of features. And you're going to look out for the differentiating factors like travel history to tropical areas or responding to antibiotics. You're going to somehow relate to the cysts in the stool or the stool sample for Giardia. For Whipple's, they often will test this pass positive feature, so look out for that. And then also you're going to get these other features like the weight loss, the hyperpigmentation, lymphadenopathy, etc. All right, so we're just over halfway through, everyone. I'm so happy and that there's so many of you on this webinar. Just wanted to quickly pause and let everyone know that, again, the GI book that all of the illustrations and content from this webinar has included is right in my guide, and we're going to be giving away some of those guides at the end of this presentation in our Discord, as well as I know I briefly touched on this at the beginning, but we're going to be hosting many more webinars in the Step 1, also Step 2 tests, as well as we have so many different opportunities for students in our Discord, whether it be just an amazing network of other students, like-minded students. We host question and answers. We really answer any of your personal questions. I know everyone's personal circumstance is a little bit different when they navigate through the journey of applying to med school, being in med school, applying to residency. And so we are there to answer any specific questions for you. And we do host weekly webinars. This is just a QR code to give any of you guys who are interested 50% off lifetime access to our community, which is $4.99, which is less than what it costs to buy a coffee nowadays with inflation and everything. Crazy. But join in if you guys are interested. This will give you 50% off lifetime access, and we will come back to this at the end. Everyone stretch out for a second, take a sip of water. We have about 4 more vignettes that we're going to dive into to finish off this presentation. So we're going to be diving into now the large intestine. So we have a 21-year-old female who comes to the gastroenterologist with a referral for irritable bowel syndrome due to a 2-year history of severe abdominal pain, bloating, and episodic diarrhea. She also has lost 20 kilos over the past year. The physical exam is notable for moderate tenderness in the right lower quadrant of the abdomen. Imaging studies showing segmental bowel wall thickening with skip lesions and cobblestone appearance. Some buzzwords, guys. The patient is most likely to have which of the following additional findings? Really great, everyone. If you're saying B, And what diagnosis is this? Yeah, really, really good. Just to go over the other answer choices briefly, guys, colonychia is classically going to be in your iron deficiency anemia. So look out for conditions that can cause heavy bleeding, etc. We talked about transmural bowel inflammation. It's going to be in keeping with Crohn's. Your crypt abscesses is going to be the other IBD, which is your ulcerative colitis, which is going to be really key in differentiating. And then villus atrophy is seen in our past vignette, which is your celiac. So let's dive into inflammatory bowel disease, and particularly how we're going to differentiate Crohn's and ulcerative colitis. This is 100% going to be tested somehow, I can guarantee you. It's just very, very high yield. And so making sure to have everything down pat with these two is very important. So let's go through it one by one. So in Crohn's disease, feel free to use any little mnemonic you like, but the key thing is going to be that your entire GI tract is going to be affected. Okay, you're going to get the skip lesions, as you can see here. So it's not going to be a continuous involvement like we see in ulcerative colitis. You're going to have this transmural inflammation of all the walls, and smoking is going to be a risk factor. Okay. The other component I want you guys to understand is that it's going to be a Th1 mediated, okay, response. It's going to classically spare the rectum, and it's going to have associations with our ASCA. Okay. So I want everyone to pay attention to Th1 for a second, because they can test this from an immunology standpoint. So what else is a feature of Crohn's, everyone? It came up in a previous vignette that I talk about, but we have our non-caseating granulomas, right? So everyone, I want you to follow this kind of pathway. So our antigens are going to be presented to our macrophages, okay? And what is going to happen, right? Our macrophages secrete IL-12, which is going to induce our CD4 cells into the Th1 phenotype, right? These Th1 cells are going to secrete IL-2, which stimulates our T cells, and interferon gamma. Now, what does interferon gamma do, everyone? Interferon gamma activates the macrophages into epithelioid histocytes, which is that classic maintaining feature of our granulomas, right? And so really, really important to keep in mind that flow chart. And then classically, your TNF alpha is going to maintain that granuloma, okay? And so that's why we give immunologics like infliximab, right, which counteracts our TNF alpha. And so I just want you guys to always think, especially for the step 1 exam, how you're going to integrate it back into your basic science principles, how you're going to integrate it into immunology, right? Your first 3 chapters of pathoma, super high yield, go over that 3 times before your test one day. And always think about, the biochemistry, genetics, immunology, and how any of these pathologies can somehow tie back to that, because that's what the step 1 likes to test. Okay. Yeah, so I do have an immunology guide coming out next. The MSK guide is about to release. I see your question there, Lexi. Our MSK guide is coming out tomorrow. MSK German connective tissue, and I'm working on infection immunity next. So, what I just said with the granuloma pathway and things like that will all be in that guide. We will have this lecture posted in the Discord community and also on my YouTube after this as well. So if you need to go back and timestamp this pot, definitely do that. So let's contrast that to ulcerative colitis, which you can think of in a fun mnemonic like this: ulcers. Okay, you're going to have continuous involvement that we talked about, right? This is going to involve the rectum, right? And that's why we're going to get our red, bloody, classic diarrhea, right? And it's going to extend proximally, and it's going to have associations with primary sclerosing cholangitis, which is where this P-ANCA comes in here, guys. So again, any markers are super high yield on the USMLE. So remember your P-ANCA associations, right, with UC and sclerosing cholangitis. And then one of the only conditions you guys need to know where smoking is actually protective is ulcerative colitis, okay? I know it sounds crazy, but it's something you need to know. Now, complications of each of these in particular, let's go through. So on our left here, we have complications of Crohn's disease, which is our strictures, your kidney stones, fistulas, and abscess. On the right-hand side, we've already talked about primary sclerosing cholangitis. We have an increased risk of colorectal cancer, so that's really important as well to hone in on. And then finally, we have this picture of toxic megacolon. So if they give you a vignette, classically with the features of ulcerative colitis, but then the patient presents with profuse diarrhea, severe abdo pain, shock, right? Look for shock with the vitals, like severely hypotensive, etc. I want you to think of toxic megacolon, which is that massively distended, greater than 6 centimeter, right, colon, and then all the signs we just talked about. Investigation-wise, it is super key that you do not perform a colonoscopy if you suspect toxic megacolon, because that has risk of perforation and sepsis and death, essentially. So investigation for toxic megacolon is abdo x-ray. Okay, I've seen questions on this before. Make sure to understand that you do not want to perforate that megacolon. So abdo x-ray is going to be your first line. Other causes of toxic megacolon, we talked about a little bit about T. cruzi, right? That T. cruzi infection as it relates to Chagas disease. And then we also talked about C. difficile, right? Remember recurrent antibiotic use in a hospitalized setting. Look out for C. diff that can also cause that toxic megacolon, okay? Now, briefly for the pharmacology, I talked about why you'd give biologics due to this Th1 mediated mechanism. You see as a Th2 mediated mechanism. And then you can give other things like azithromycin, corticosteroids on the Crohn's disease side, and then 5-aminosalicylic acid on the ulcerative colitis side, okay? And finally, wanted to end with that integration here that sclerosing cholangitis, ulcerative colitis, microscopic polyangiitis, and Churg-Strauss syndrome, all Pianka, okay? All Pianka, really, really high yield to remember that. Something like, and then contrast that again, guys, with like Cianca, right? Which is going to be part of some of your vasculitis. But Pianka, high yield to know those associations. Pancreas, gallbladder, and pathology. Let's dive into it. So we have 6-year-old male, 31 pack year smoking history, presents to the emergency department with complaints of jaundice, pruritus, unintentional weight loss over the past several months. Imaging reveals obstructing pancreatic mass for the patient, and he undergoes a surgical resection. Following surgery, the patient is referred to an oncologist for further management of chemotherapy. The oncologist explains to the patient that they'll be monitoring the patient's cancer for progression. Yeah, I probably don't even need to finish this. A lot of you guys are already going. What tumor marker is implicated here? Yeah. Good. Everyone's saying D, pancreatic adenocarcinoma. Great. Rapid review quickly. CEA, colorectal cancer, PSA, prostate cancer, AFP, many cancers, but a big one is hepatocellular carcinoma. We talked about 19.9 with pancreatic, and then CA125 is your ovarian cancer, right? Good job, everyone. So quickly wanted to just do this little flow chart of acute pancreatitis to chronic, and then to pancreatic adenocarcinoma. So I think everyone's heard of the I get smashed mnemonic, but particularly gallstones and ethanol are going to be your most common causes of acute pancreatitis. Classically look for, right, that acute epigastric pain that might radiate to the back. Diagnostically look for serum amylase or lipase. And then you're also going to want imaging. And 2 of 3 of these features is going to be confirmatory for acute pancreatitis. There's some other high yield causes here, but really the gallstones and ethanol are the ones I've seen tested, or that crazy obscure scorpions thing. But yeah, just focus on those high yield ones. If you get recurrent bouts of acute pancreatitis, or this occurs over time, like for instance, like chronic alcohol use, for instance, you can get chronic pancreatitis, which is going to be this chronic inflammation, atrophy, and calcification. And then look out for signs, right, of pancreatic insufficiency, which is your steatorrhea, your vitamin A, D, E, K, which is your fat-soluble vitamins, right? Those ones are implicated, and then diabetes, right? If remember, pancreas both has an endocrine function and an exocrine function, right? So both remember your insulin, beta cells, alpha cells, and glucagon, et cetera, and then also stay on the lookout for the endocrine functions as well. Risk factors of course, alcohol use disorder and cystic fibrosis. And then you can get this complication of a pancreatic pseudocyst. And I've seen a UWorld question, I think an NBME question on this. Remember that your pancreatic pseudocyst is lined by granulation tissue and not epithelium. Okay, just a little factoid to remember. Now, coming back to our question at hand, you're going to look out for this positive Courvoisier sign, which is going to be an obstructive jaundice and a non-tender bladder, okay? Non-tender gallbladder, okay? So unfortunately, pancreatic adenocarcinomas are very aggressive and they have a poor prognosis. They most commonly occur at the head of the pancreas here. And then, of course, again, my fun memory tricks right in my guide. I think of pancreas, you turn the 9 to the side, it looks like a pancreas. And then look at this one. It's also implicated with the KRAS mutation. And look at that, pancreas. Okay. Really, really easy memory tricks to remember that. Your number one risk factor for pancreatic adenocarcinoma is going to be a smoking history, but also look out for diabetes and, of course, the sequelae of chronic pancreatitis. And then finally, a key feature or a common associated syndrome, if you may, of pancreatic adenocarcinoma is going to be your migratory thrombophlebitis. And so this is a prothrombotic state, right, where you're going to get clots essentially. And so hallmark features or signs of this in the vignette is going to be like painful red extremities. So look out for that and its association with pancreatic adenocarcinoma. All right, we're going to go into some liver pathology. Guys, we only have a few more left, so stay active, stay engaged, and let's get on to the next one. So we're going to be going into some Hep B serology here. We have a 35-year-old male, presents to the primary care physician for routine follow-up. He undergoes blood work for hepatitis B. Laboratory investigations reveal the following serum serologies. So our surface antigen, our Hep B surface antigen is going to be positive. Hep E, HBE, right, our envelope one is going to be positive. And then our antibodies, okay, we're going to have a positive IgG. We're going to have a negative antibody to HBS. And then, okay, I already see many of you guys putting your answers in there. Great job, everyone, if you're saying B. And we will go one by one through the serology because this is also super, super high yield and often tested. So this is a little bit of a flow chart of the different markers that are going to be elevated and when. So the first thing when you're exposed to the infection, right, your surface antigens are going to be exposed right here in green. And I have lovely memory tricks for you guys to help remember this. And so the first one here we're going to work with is the S is going to help you remember sick. So I want you to remember S with sick because if you have a positive HBsAg, then you are sick with Hep B. You acutely or chronically have the infection, and we're going to use the other ones to differentiate if you're chronic, acute, or infection in the past. Okay. Now our HBe, our envelope antigen, is going to be elevated in neonates specifically at birth. So that's a key association. But I want you to remember E with easily spread because if this is positive in your serology, then the patient is actively infected. Okay, they're actively infected. Now, for our antibodies, okay, so we have these first two that we've talked about. Now we have anti-HBC, okay, which is going to come on around the 2-month mark and then stay elevated. This is going to be your marker, right, that helped us differentiate between an acute and chronic infection, because this one's going to stand for came across Hep B. So you either had a previous or you have an ongoing infection. And what's going to help determine this is your IgM versus your IgG. Remember, you go to your mom first when you're sick. So acute first marker elevated is IgM. IgG, greater time period, IgG is chronic, okay? The other really, really important thing that can be tested is that look at this window period, everyone. The only marker that's going to be detectable in this period is going to be your anti-HBC. Okay, so you can also remember that you can see through the window with the anti-HBC marker. Now, I told you guys to pay attention to the S with sick and E with easily spread, right? So so your antibodies now to HBS is going to be anti-sick. Okay, really easy to remember that. That's either going to be through immunity or vaccination. If you are vaccinated, everyone, this is the only marker that's going to be elevated. Okay, so they could have given you a picture where this was the only elevated marker, and you have to know that they've just been previously vaccinated. Okay, they haven't had any active infection. They haven't developed these antibodies such as these ones, okay? And we've talked about how E is going to be easily spread. So what is anti-easily spread? That means it's going to have a low transmissibility, as you can see in orange and in red here. Now, a little memory trick also to remember this is that in the second period, right here, in the second period, anti-HBsEC, SEC is going to be elevated. So you're going to have your, right, HBS, HBC, HBE. So I want you guys to be able to identify in an acute infection, a resolved infection, immunized state, susceptible state, or a highly infectious state. And essentially with these memory tricks, you should be able to answer every single one. So our last part of this presentation is going to be on hernias, and it's going to tie in some anatomy, okay? So we have a 45-year-old who presents to the primary care physician with a bulge in the groin that appears with straining and disappears when lying down. Physical examination reveals a reducible mass in the inguinal region that protrudes through the internal inguinal ring lateral to the inferior epigastric vessels. What is the underlying anatomical defect responsible for this type of hernia? Everyone in the chat box, this is your last question. So I want every single person on this webinar to put in their thoughts here. Now, this is a little bit of a trick, everyone. This is a little bit of a trick. Lateral to the inferior epigastric vessels, guys. Lateral. Is this an indirect or direct hernia? Indirect. Indirect. And I know, really, really good, guys. So if you're saying C now, you're correct. And I know classically we always want to associate our direct hernias, right, with the weakness of the transversalis fascia, right, with older adults only. And we only want to associate indirect hernias with newborns due to this problem of the process vaginalis, right, to obliterate. But actually, indirect hernias can actually present it's bimodally. So it's in the newborns essentially, or early on in life, but also towards the end of life. So it is correct to say that hydrocele is related to an indirect hernia because it's the same embryological failure of obliteration, but they have relationships with the spermatic cord and where it herniates. So what I want to do here, and hopefully this will clear up some things for everyone, is just go through both indirect and direct hernias, which both occur above the inguinal ligament. And you've probably heard this mnemonic, which is MDs don't lie, which is going to help you remember that direct hernias occur medial to the inferior epigastric, indirect occur lateral to the inferior epigastric. So, right, as I said here, that's the first most important thing that you're going to identify is where this herniation occurs. Know that the direct hernia is going to go through the superficial ring, right? This external inguinal ring, and it's going to protrude directly through an area called the Hesselbach triangle, which is a weakness in our membrane of the transversus fascia, okay? Common in older males, classically. If we contrast this to our indirect hernias, okay, it's going to occur, what did he say? MDs don't lie, lateral. So as we saw in the vignette, and this is going to be most common in both infants and males. And I talked about how this is a failure of the processus vaginalis to close, which is our answer choice. But this one particularly, guys, it's important to note that it's going to go through the internal inguinal ring and the external superior ring, okay? So really important, and you can remember indirect also goes through the internal inguinal ring. That's a fun memory trick. But I did want to just hone in on, don't be fooled if they give you an older adult with this hernia picture and you immediately rule out an indirect. Right in the vignette, it said it happened lateral to the epigastric artery. And if they tell you that, you know it's an indirect, and you know that that can stem from the failure of the process vaginalis to close, okay? And exactly a HOD, which is a beautiful way to tie that back in, a patent process vaginalis, right, can also lead to hydrocele, which is accumulation in the sac, which is accurate, which is completely accurate. Now, I wanted to just do one other integration here, and that's our femoral hernias. These are more common in females, so that's really easy to remember. But these ones both happen below the inguinal ligament, and these ones have higher risk of complications. Okay, so these ones most likely are to become strangulated, etc. And so they typically have a more urgent need to surgically intervene. Okay. Now, that really concludes everything that I had from this presentation. I also did want to talk about one last thing when it comes to embryology. And I think in the, right here. Failed resorption of the omphalomesenteric duct or the vitelline duct. What is that, everyone? Just as an active recall practice. Meckel's. Really good. Meckel's, I want you to think of your rule of twos, right? In the first 2 years of life, 2 feet from the ileocecal valve, The other thing I want you guys to understand is that your Meckel's diverticulum is a true diverticulum, which is an outpoaching all the layers. Okay. Also, remember, right, you're going to do that scintigraphy scan to look for that ectopic gastric pancreatic tissue. And I want you to contrast that with false diverticulums, where it's no serosa. So how you differentiate true from false diverticulum is true is going to be all the layers, false is going to be all the layers except the serosa. And that one, I want you to think of Zenker's diverticulum, right, which is classically in older adults. They're going to have that foul smelling breath, right, the halitosis, dysphagia, and it's going to be weakness in that Killian triangle, okay? The other cause of a false diverticulum is your diverticulosis and diverticulitis, and that you're going to look out for painless hematochezia, so painless bleeding in the stool in an old patient. And then the final integration I wanted to tie in was a persistent ophthalmo-mesenteric duct or vitelline duct, also known, so the same thing, ophthalmo-mesenteric and vitelline duct, same thing. If you get a persistent vitelline duct, classically, you're going to get meconium through the umbilicus, okay? I want to contrast that to an allantois, right, where you get a persistent or patent urachus, and that's going to be pee from the umbilicus, okay? So keep in mind those embryological tie-ins. I thought I'd just quickly go back there and talk about that. And of course, weakness of transversalis fascia is going to be your direct hernias. So guys, I hope you enjoyed this webinar. It's a pleasure doing this and having so many of you from wherever you are join in. Have some active recall, have some high yield review. If you're writing your step 1 exam soon, good luck. Definitely check out my resources and guides. I think they can help a lot. The other thing is make sure to also download my USMLE study pack, because I go over the highest yield kind of resources and what to do in your months leading up to the exam. I already talked about pathoma in chapters 1 to 3, which were essential in my prep. But really glad and happy for you guys. Reach out if you guys need anything. And again, if you guys want to join webinars like this on a weekly basis, if you guys want to join a community of thousands of students, like-minded students who are studying for their step exams, who are applying for residencies, who are Denise, Akira, Ahad. Yeah, thank you guys, everyone, for coming in. But yeah, if you guys are interested in any of that, be sure to join my Discord. The QR code will give you a 50% lifetime access to our community. I do have a neurology and cardiology webinar posted on my YouTube if you guys want to check that out. Thank you guys so much. Loved having all of you guys join me for this session. Stay tuned. In the next few weeks, I'll be doing an endocrinology webinar, so stay tuned for that.